welcome to all present here for the week-long webinar. Today is the third day, and we have had a very wonderful session on the first and second day. And we are happy to tell you that we are here for the third day, and we are hoping that this also will be as successful as first and second day. And we'll start with the IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you, everybody. And before handing over the session to Dr. Jayaraman, I just want to tell all of you that we are live on Facebook, Twitter, and YouTube. So those of you who have friends who don't have a Zoom app can join in any of these. Thank you, and over to Dr. Jayaraman.
Thank you, ma'am. Good evening. Welcome to one and all. First of all, I thank IMA headquarters, New Delhi, and IMA College of General Practitioners headquarters, Chennai. Dr. J. Jailal sir, Dr. J. Slele, Dr. Anbar sir, Dean Natwar sir, and Rekha ma'am, Yasoda ma'am, and Anbarajan sir. So this is a wonderful platform to commemorate the World Lung Day. So this is today is the third day. We're going to discuss in detail about each and every disease in every day. Yesterday we discussed tuberculosis, yesterday airway disease. Today we're going to discuss about the plural diseases. So World Lung Day every year in the month of September 25th, as per the recommendation of WHO, we are doing as an awareness program for the entire world. This year, the theme of this World Lung Day 2021 is the care for your lungs by four methods. One is say no to tobacco, get your vaccinations, breathe clean air, and take regular physical activity. This is the four themes under these care for your lungs. So we are working hard to create a lung health awareness to the entire globe. So today we have a wonderful session. We're going to discuss about the plural diseases. In plural disease, there are many plural tumors, pleural effusion due to many etiologies like infection, failure, and malignancy. And we have a pleural pneumothorax and all. Pneumothorax mostly is a catchy pain, one of the emergencies. So the common presentation of a general practice point of view, the pleural effusion is one of the common 5 to 10% of the respiratory cases they used to present with the general physician, the cough and breathlessness, fever and all. So we have to evaluate it correctly. And in our country, we're all TB is one of the endemic in our area. So any pleural effusion, we tend to diagnose, sometimes over-diagnose the tuberculous pleural effusion and start the ATT and all. Then patient present again and again with recurrent pleural effusion, with the hemorrhagic effusion, and the 2 to 3 months later only they refer to interventional pulmonologists for the correct, accurate procedures, how to diagnose and all. So today we have 2 eminent speakers. One is Professor Dr. T. Dhanashekhar. He's going to speak on approach to pleural effusion from Chennai. Another the speaker from Puducherry, Professor Dr. S. Yuvarajan, is going to speak on management of pleural effusion. So this is a wonderful session. There is no doubt. Professor Dr. T. Dhanashekhar is our scientific chairman, the architect of this program. Professor Dhanashekhar is a professor and head of the department, Sri Ramachandra Medical University, Chennai. And he organizes several conferences and examiner for DNB and MD students in pulmonology. And he has several publications in all the respiratory diseases. And he is an interventional pulmonologist and somnologist practicing in Anna Nagar. And he is the professor head of the Ramachandra. And with this, I hand over the mic to Professor Dr. T. Dhanashekhar about the approach to pleural effusion. Over to Dr. Dhanashekhar, sir.
Thank you, sir. Thank you, sir, for your wonderful introduction. And once again, I thank the IMA and the general practice, IMA general practitioners and the organizing committee for giving us this opportunity. And today's topic of mine is pleural effusion. And able to see, sir?
Yes, sir. It's opening.
Yes.
Yes.
Today, my topic is on pleural effusion, and in another 20 to 30 minutes, I'll be briefing you about the basics, what is the anatomy, what is the physiology behind the pleural effusion, what are the causes of pleural effusion, whether it is a transitive or exudative effusion, and I will come back on this. To recap on the normal dynamics of the pleural fluid, and also about the role of imaging in the diagnosis of pleural effusion, and how to interpret the pleural fluid analysis. And
sir, can you make the slideshow? Can you make the slideshow?
Full screen, sir. Full screen.
Yes, sir. Yes, sir. 1 minute, sir. Able to see, sir?
Yeah, fine.
Okay.
Fantastic.
Okay.
So I'll be talking to you about the role of imaging in the diagnosis of pleural effusion and the interpretation of the pleural fluid analysis, and in what way, in which time we have to refer, and what are the causes of pleural effusion, all those together I'll be talking to you. And coming to the introduction, the pleura and the lung are intimately associated, and it may share many pathological conditions of the same. And pleural diseases is truly a mirror image of the systemic diseases. Most of them, like connective tissue disorders, can present with pleural effusion alone, like rheumatoid arthritis and SLE can present with the pleural effusion. So these are the systemic diseases can also present as a pleural effusion. So it's a pleural disease, truly a mirror of the diseases in the thorax and the systemic diseases. Pleural effusion can develop as a result of 50 different pleuropulmonary or systemic disorders. In 20% of the patients, most of the time, the pleural fluid is diagnosis cannot be made out. It's called as an undiagnosed pleural effusion. And I'll touch that also in my talk. Coming to the definition of pleural effusion, is the accumulation of fluid within the pleural space due to the imbalance between the formation of the pleural fluid and the absorption of the disease state. And abnormal accumulation of fluid in the pleural space is irrespective of the underlying cause is called as a pleural effusion. And if there is a blood in the pleural cavity, it is called as a hemothorax. If it is a chyle inside the pleural cavity, it is called as a chylothorax. If there is a pus inside the pleural cavity, it is called as an empyema. If you have any urine inside the pleural cavity, it is called as a urinothorax. So different spectrum can be there. You have a different causes of pleural effusion. So coming to the anatomy, we have two types of pleura. One is a parietal pleura and visceral pleura. And parietal pleura is the one which is painful, whereas the visceral pleura is attached to the parenchyma of the lung. And the space between the two visceral and parietal pleura is called as a pleural space. If there is any accumulation of fluid inside the pleural space, it's called as a pleural effusion. Normally, it is around 10 to 20 microns in width. And as I told you, what is the mechanism why they get accumulated is difference between the hydrostatic pressure and the oncotic pressure. Hydrostatic pressure is a driving pressure for the formation, whereas the oncotic pressure is the opposing pressure for the inside the pleural cavity. I'll come to that in detail. The passage formation and absorption is mainly by the passage of protein fluid across the pleura, depend on the hydrostatic pressure and the oncotic pressure. What is the hydrostatic pressure? That moves the systemic capillary pressure, which pushes the fluid inside the pleural cavity, where that is, if the systemic capillary pressure is 30, whereas the negative pleural pressure will be around -5, so it will be the total net hydrostatic pressure will be +35. Whereas the net oncotic pressure is a systemic capillary oncotic pressure is 34, whereas the pleural fluid oncotic pressure of 5 is a difference of 29 will be there. So there is a difference which causes the fluid to form inside the pleural cavity. So this is how most of the time in the parietal pleura, which causes the accumulation, which secretes pleural fluid, and the imbalance between the hydrostatic pressure and the absorption and the formation difference will produce the pleural effusion. So what is the normal physiology? The total pleural fluid volume is 0.2 to 0.3 ml per kg, and the rate of fluid formation is 0.01 ml per kg per hour. And this, I'm just talking about the basic physiology. I'm not coming to that in detail. The rate of fluid clearance is absorption is 0.2 ml per kg per hour. So the rate of formation and absorption are equal. That's 0.01 to 0.02 ml per kg per hour. And the normal amount on each side will be, the normal amount of pleural fluid will be less than 10 ml. And it's primarily a hypocellular, 1500 to 2000 cells per ml will be there. And the pleural fluid will be alkaline in nature. And mostly the 75% are monocytes and macrophages, and 23% are lymphocytic. And you have 2% granulocytes, mesothelial cells, and erythrocytes can be there. And the normal, they have a low protein if it is 15% of the plasma protein. So this is the normal content of the pleural fluid. So mechanism of pleural effusion is if there is an increased pulmonary capillary pressure, that is a mechanism for congestive cardiac failure. In congestive cardiac failure, you can get a bilateral effusion or an unilateral effusion. Most of the time, it will be a transitive effusion. What is the mechanism of pleural fluid formation in pneumonia is increase in the pulmonary capillary permeability. Because of the interleukins, all those things, the vessels get increase in the permeability that will produce the fluid formation. And decreased intrapleural pressure is because of the collapse of the lung or in the trapped lung, you will get, this is the mechanism. And decrease in the oncotic pressure in hypoalbuminemia, as you all know. And in malignancies, it may be because of the increase in the permeability or sometimes with the obstruction of the lymphatics that may be the cause for pleural effusion in malignancies and infection. And in diaphragmatic, if there is a hepatic hydrothorax or an ascites, the diaphragmatic defect will produce through the diaphragmatic defect, it will reach the pleural space. Then if there is a chyle got injured, they can get a chylothorax. In case of injury to the kidney by trauma, you can sometimes get a urinothorax. These are the mechanisms by which you have the different causes of pleural fluid formation. As the same thing as I told, it's an increase in the hydrostatic pressure. Elevated capillary wedge pressure is determined for the congestive cardiac failure. Hypoalbuminemia, ascites moved in from the ascites from the peritoneum. It moves through the diaphragmatic holes and it reaches the pleural space. And it is a trapped lung, as I told, pneumonia is the same thing. So the causes of transitive pleural effusion. So as I told you, what is the mechanism of pleural effusion, how it is formed. What are the causes of transitive pleural effusion? Transitive pleural effusion, you have a congestive cardiac failure, cirrhosis of liver, nephrotic syndrome, urinothorax, myxedema, that is hypothyroidism-induced pleural effusion, or sometimes a CS leak into the pleura, very rare, and trapped lung. These are all produce a transitive pleural effusion. I'll come to that, what is transitive effusion and what is a exudative effusion. I'll talk to you in the later part of my slide. This is an exudative effusion where you can see in malignancies, pneumonias, most common in tuberculosis, pulmonary embolism, pancreatic effusion, post-CABG, pericardial disease, SLE, rheumatoid arthritis, uremia, chylothorax, all these are exudative pleural effusions. How will you approach a case of pleural effusion? So a patient is presenting with pleural effusion. What are the clinical symptoms the patient will have? First, I talk to you about the anatomy. What is the mechanism? What are the types of effusion? You have a transitive effusion and exudative effusion. Now you know what is a effusion, how it is formed. Now I am going into the how to approach a case of any patient who is coming to you to a clinic or a hospital. You have to take a detailed history taking is mostly important. I always stress my students to detail take about the history and physical examination. That will give us a more clue to conclude on your etiology also. The occupation is more important. Sometimes in cases who are working in asbestos in the related industries like mining and shipyard, they are more prone to develop asbestos related mesothelioma and mesothelioma with pleural effusion. So occupation is also more important, and smoking is more important because most of the time the smokers can develop malignancy. It may be a primary in the lung with or metastasis in the pleura from the other parts of the body. And tuberculosis is whether the patient has a history of tuberculosis, whether the patient has been treated for tuberculosis, any contact history of tuberculosis. That is more important. Any father or mother or some in the family members who are sputum positive tuberculosis, that is will give you as a clue whether the etiology may be tuberculosis. Whether the patient had a history of prior malignancy, like most commonly we see is a tuberculosis, is a breast tumor, where if they have a breast tumor in the past, whether mastectomy done, sometimes they will present with effusion. You have to rule out malignancy as a cause, whether it is secondary to the malignancy. And other chief complaint, what is the most common complaint with which the patient will present to you is dry cough. The patient will have pleuritic chest pain, and the patient will have difficulty in breathing. These are the main thing. The patient will have the symptoms, and in the occupation you should ask all these histories, and in the complaints the patient will have invariably all three or all two or one, which will give us a clue. On examination you will have a apical impulse may be shifted. You can see the tracheal shift if there is a massive effusion, and you will have a chest movements will be decreased on the side of the pleural effusion. If the patient is having a right side pleural effusion, the patient will have a shift of mediastinum towards the left side, and the patient will have decreased movement of the chest wall on the right side. And on percussion, the patient will have stony dullness on percussion, and VF/VR will be decreased, and absent breath sounds or decreased breath sound will be there in case of a pleural effusion. Very rarely you will get a pleural rub on the lateral aspect of the chest. So, whether what are the things which we give you a clue in finding out the cause of pleural effusion? If the patient is having ascites, the patient may have a primary cause maybe in the abdomen. If the patient is presenting with lymphadenopathy, the cause may be tuberculosis or malignancy. These are the clues you have to pick up on examination itself. If the patient is having clubbing, you have to rule out malignancy and empyema. If the patient is having right ventricular heave, thrombophlebitis, tachycardia, you have to think of pulmonary embolism with cor pulmonale, maybe the cause of pleural effusion. If they have a signs of consolidations like crackles, and that will give you a clue with the pleuritic pain, will give you a clue where the patient is having a parapneumonic effusion. If they have a distended neck veins, you can have a patients with CCF, congestive cardiac failure, presenting with pedal edema, bilateral effusion. So all these things will give you a clue for the diagnosis of your cause of pleural effusion. So what are the images you know? You can take X-ray chest PA view, lateral view, and lateral decubitus view, which most commonly as a general practitioner, as a routine practice, we take a PA view. And nowadays we do an ultrasound in all cases of pleural effusion. We know the whether it is sometimes you can with the floats inside, if you have fibrins inside, you can think in terms of a exudative effusion. Very rarely you will get a transitive effusion, can also be picked up by the ultrasound, and you can quantify the amount of fluid. You can tap the pleural fluid under the guidance of ultrasound, which will give you a clue how to what may be the etiology. Sometimes you can, if they have a consolidation, can be picked up by ultrasound itself. So, and computer tomography is also one of the imaging tool. I'll come to that. And to assess the quantity of the fluid, whether it is a loculated pleural effusion or a generalized pleural effusion, and to look for the associated intrathoracic abnormalities, like if they have a consolidation, can be picked up by the images. So this is a case of a right side pleural effusion. You can see the fluid going up. It's called as an Ellis curve, typically seen in a PA view. This is a case of a right side pleural effusion. So this is a case of a bilateral pleural effusion. You can see the Ellis curve here as well as here. This patient, the cause may, as I told you, if there is a bilateral pleural effusion, you have to think of any intra-abdominal cause, like if there is an ascites, or it is a congestive cardiac failure or renal failure presenting with bilateral effusion. if they have a minimal effusion, you can take a lateral decubitous view, which will give you a clue whether the patient can be this diameter from the chest wall to the topmost part of the fluid. It should be more than 10 millimeters. If there is more than 10 millimeters, you can try the aspiration of fluid. Otherwise, you should not touch the blind aspiration should not be done, and you can do under ultrasound guidance. This previously during our PG days, we used to do a lateral decubitous in patients who are having a minimal pleural effusion or only the CP angle is blunted or not. Nowadays, with the advent of ultrasound, we are not doing routinely the lateral decubitous view. Just to put what is lateral decubitous view, I put this slide. And this is a minimal effusion CP angle blunting on the right side. You can see the anterior loculation is there. You can see the pleural fluid here, but whereas here in the posterior sulcus, it's free. What is this? This is a fissural effusion. You can see the fissural effusion here. What is this? This is a minor fissure effusion. These are some radiological features you have to pick up as a general practitioner. You can easily pick up in the PA view itself. And this is called as a lateral beaking sign, where you can see here suddenly there will be a peak followed by a drop. So this is a subpulmonic effusion. This is called as a lateral peaking sign, usually seen in patients with loculated. This is also one of the loculated effusion. So this is a subpulmonic effusion. So what are the volumes which you can quantify? If the patient is having a obliteration of the CP angle or a subpulmonic effusion, usually the amount of fluid, approximate amount of fluid will be 50 to 75 ml. If there is an obliteration of the CP angle alone, you will have a 150 to 200 ml. If there is a diaphragm is not able to see clearly because of the fluid, then you can have an approximate 500 ml. If the effusion is up to the fourth anterior rib, it is around 1000 ml, moderate effusion. If it is in a lateral decubitous view, as I told, you can pick up to 10 to 20 ml can be diagnosed. And role of ultrasound, as I told, it's you can find out whether it is a free effusion or a loculated effusion. Is there any septations are there? Sometimes you can differentiate between transitive and exudate. And if it is a loculated or a solid mass is there, and you can mark the site and depth of the fluid, and you can go under the ultrasound guidance and you can safely do a pleural aspiration. So this is an ultrasound picture. This is a diaphragm, you can see clearly, and this is the effusion, and this is the lung. So with this, you can put a needle from here, you can directly reach into the effusion. You can see the needle. By moving the needle, you can visualize by the ultrasound, and you can tap the fluid with the comfort. And most of the time, once you have a pleural effusion, you want to know whether it is a transitory effusion or exudative effusion, and what is the cause of the disease. Previously itself, I told you what are the causes of transitory effusion and what are the causes of exudative effusion. And you can only predict the answer by the two questions. One, you have to do a thoracentesis. You have to aspirate the fluid and find out whether it is a transitive or exudate. And every patient has to undergo a diagnostic as a trapping of the fluid, or if they have a massive fluid, you have to do a therapeutic aspiration. Sorry. So, is there any contraindication for pleural aspiration or thoracentesis? Absolutely none. If they have a bleeding diathesis or a very small fluid, as I told, if it is less than 10 ml, or if they have an active skin infection over the site of aspiration, or the patient on a mechanical ventilation where they are more prone for a high-risk pneumothorax, but it can be done under a ultrasound guidance. Post-procedure observation is needed, and post-procedure chest X-ray if the patient is having a severe cough or The cause may be because if the patient is having severe cough, you have to stop the pleural aspiration, and it may be because of the expansion pulmonary edema. But you can have a pleural manometry, which will help you in which will help you or guide you in aspiration of fluid. One of my postgraduates is doing a dissertation on how much, if you remove the fluid, the patient is developing cough, and with the manometry, up to how much you can aspirate. So the manometry is coming into the picture now, and it will help you in helping you to prevent re-expansion pulmonary edema. This is how you should aspirate, and you can see the 3-wave adapter. You have to have a 3-way adapter with a 50 ml syringe, which I was aspirating. You can see you can completely aspirate, and you have to close every time to prevent any entering of air into the pleural space. So coming to the pleural aspiration, with, as I told you, with the while you have started aspiration now, and with the color of the fluid itself, you can come to the diagnosis, which will give you a clue in the diagnosis. That is, if you have a pale or a straw color, it may be a transitive. If it is a blood, what I have aspirated, you can see in the picture, if it is a blood, it may be a malignancy, is most common. If there is a white milk color, I'll show you the pictures, it can be a chylothorax. If it is a blood, a brown, it may be a long-standing blood, or a black, sometimes in aspiration is very rare. Sometimes you can aspirate a food particles. That is easy. If they have an esophageal perforation, you can get, but that's also very rare. If you have a yellow or green, you can have a because of rheumatoid pleurisy. And if it is a dark green, sometimes bile can be aspirated. I have seen bile, I have seen urinothorax, where you will have a very clear fluid. Once you have to keep the eyes open and smell sometimes, which will give you a clue in the diagnosis of urinothorax. So this is which I have aspirated. This is a case of a malignant mesothelioma with a malignant pleural effusion. With you can see the hemorrhagic pleural effusion. The primary lung tumor can present, or it may be a mesothelioma, or in the metastasis in the pleura can present with hemorrhagic effusion. Very rarely, tuberculosis can also present with hemorrhagic effusion. This while aspirating itself, you can find out this is a case of a chyle. So we immediately did a ether test to confirm whether it is a chylothorax or pseudo-chylothorax by putting alcohol into it, mixing. If they have a debris, you can differentiate in that. This is a typical case of a chylothorax. You can see this is a ether test. So the lights criteria will, I told you previously what is a transitive effusion, what are the causes. Now I'll give you what is transitive, what is an exudate. Now you are aspirating the pleural fluid and sending for analysis. If the pleural fluid serum protein divided by serum protein, if the ratio is less than 0.5, it is transitive. If it is more than 0.5, it is an exudate. And the serum LDH by pleural fluid LDH, if it is less than 200, it is a transitate. If it is more than 200, it is an exudate. And if we have a pleural fluid LDH by serum LDH ratio, if it is less than 0.6, it's a transitate. If it is more than 0.6, it's a exudate. And this is a person who designer who is the one responsible for this lights criteria. It's called as lights. It's a standard book which we all follow for the pleural diseases. The lights criteria, when he was only just 32 age, at the age of 32, he formed this lights criteria, and which is a gold standard method and which we are following now also. And there is a newer criteria where you can have a cholesterol inside it. If you have a cholesterol of less than 45, it is a transitate. If you have more than 45% milligrams per deciliter, then it is an exudative effusion. This is one of the add-on along with the lights criteria. And to distinguish how much is the sensitivity of the lights criteria, and the sensitivity for exudative effusion is 98%, but the specificity is 83%. Whereas if you are adding cholesterol, the sensitivity is 54%, whereas the specificity is 92%. And the ratio of pleural fluid cholesterol by the serum cholesterol of more than 0.3 will give you a 89% sensitivity and 81% specificity. So this Lights criteria is a gold standard which we follow. Along with that, we can add cholesterol, which will give you a added information for differentiating transitive and pleural effusion. Anything, whether you can have a Lights criteria can go wrong. Yes, it can go wrong. If it usually in congestive cardiac failure, you will get a transitive effusion. If the patient is on diuretics, they can produce a exudative effusion. If it is a transitive effusion, avoid additional tests and do directly find out the cause, whether it is a cardiac cause or hepatic cause, or it may be a renal cause. You have to find out, and you have to treat the primary cause, and all the effusions can come down. And common test for pleural fluid, and I think is a cell count, pH, glucose, LDH, cytology, and test for tuberculosis. I'll come to that in a few minutes. And the pleural fluid cell count, if it's a neutrophilic, you have to think of a paramnemonic effusion or a pancreatic effusion. That's a 3 P's: paramnemonic effusion, pulmonary embolism, and pancreatic effusion. If the patient is having a pleural fluid analysis, if we have an increase in the neutrophil count, you have to think of these three: paramnemonic effusion, pulmonary embolism, and pancreatic effusion. If it is a lymphocytic predominant, you have to think of tuberculosis. Any chronic process like malignancy sometimes can present with lymphocytes. Post CABG, you can get lymphocytic effusion. Eosinophilic effusion is a very rare. If you, while aspirating, if you put air inside the pleural space, they can present with eosinophilic effusion, or sometimes drug-induced and asbestos-induced. Most commonly, they can also present with eosinophilic effusion. With the cell type itself, you can find out what may be the probable cause. You have to segregate according to that, and then you have to decide on further investigation and further management. And you can do a pH, which is not done as a routine. If there is a paramnemonic effusion, if it is less than 7.2, you have to put an ICD. It's an ICD. And if there is a malignant effusion which is less than 7.2, very low, the life expectancy is very low if the pH is very low, and pleural disease may be ineffective. There are some studies shows that if the pH is very low, the pleural disease won't help. And the test for glucose. Glucose is more important in case of a paramnemonic effusion, malignancy, tuberculosis, and rheumatoid arthritis. You will have a low glucose level. And one clue for if they have a very, very less amount of glucose, then you have to think of a rheumatoid effusion. And rarely in lupus effusion also, you can get a low glucose. LDH usually it shows the levels of inflammation, and increased level shows increase in the inflammation. Aggressive approach is needed. You have to put an ICD, or you have to do further investigation, whether to do a culture or a gram stain. If there is a growth, you have to put an ICD. If there is a decreased level, the less. And if the LDH is more than 500 international per unit, then you have to suspect probable cause may be a neoplasm or secondary bacterial infection may be the possibility. So we touched about the cell type, we have touched about the glucose, we have touched about the LDH, we have touched about the pH. And cytology, which we have to do routinely to rule out any malignant cells. Sometimes we used to do routinely, we send all the pleural fluid for cell block cytology, and this will give you most of the time you will get a much good result rather than a plain cytology. And you can do sometimes the tumor markers in pleural fluid, and flow cytometry in pleural fluid will help in lymphoma. And thoracoscopy is a better procedure. I think in the management, Yuvraj will be covering on that. Coming to the tuberculosis, which is most common in India and which we routinely see in day-to-day practice, most common pleural effusion causes tuberculosis. That's what is the cause? Is because of the rupture of subpleural focus, and the tuberculous protein enters the pleural space. Due to hypersensitivity reaction, you will get a pleural effusion. And it may be unilateral. 30% will have a parenchymal disease most of the time in case of a tuberculous effusion. Most of the time it will be a lymphocytic effusion and exudative effusion. And if they will have a less than 5% mesothelial cells. And you have to do an AFB should be demonstrated. And AFB positive in pleural fluid is less than 25% of the cases. And AFB culture positive in more than 55% of the cases. And ADA will be more than 40 international units per liter. Will give you a diagnosis of tuberculous pleural effusion. Collagen vascular disease and pleural effusion, as I told, SLE can present with pleural fluid, and you can see a pleural fluid ANA will be positive. And in case of rheumatoid arthritis, as I told, associated very low glucose level will be there in case of a rheumatoid pleural effusion. Coming to the pulmonary embolism can present with a minimal effusion. Sometimes it may be hemorrhagic effusion. Usually they will present with chest pain and hemoptysis. As I told you, the chylous thorax, as I told you, you have to look for triglycerides, which will be more than 110. And it may be because of the rupture or trauma due to the thoracic duct. And it's one of the main thing that you have to put the patient on dietary modification, and somatostatin sometimes infusion will help in the treatment of chylothorax. Amylase will give you a pancreatic effusion. If there is a neutrophilic effusion on cell count, you have to think of a pancreatic effusion. And urinothorax, as I told, it may be the cause of obstruction may be there, or a trauma to the kidney or retroperitoneal injury can produce a urinothorax, which is very rare. And you can have the pleural fluid to serum creatinine ratio of more than 1 in the diagnosis of urinothorax. These are different things which I told you. If it's an empyema, you have to have a positive gram stain and culture. If it is a malignancy, you have to have a positive cytological testing. And if it is a chylothorax, you should have a triglyceride should be elevated. And in case of a hemothorax, to differentiate between hemorrhagic effusion, in hemothorax, you should have a hematocrit of more than 50%. So these are the different things which will give you as a clue in your management as well as in the diagnosis of what is the cause for pleural effusion. And coming to the role of CT, where it helps is to distinguish between empyema and lung abscess, or sometimes if it is a loculated, multiloculated effusion, it will help. If it is an empyema, you will get if it is a loculated effusion, it will help you. If it is a bilateral effusion with pericardial effusion, that can be picked up, most commonly seen in connective tissue disorder related pleural effusions. And you can see the split pleura sign. This is where typically seen in empyema. And along with the consolidation, you have an effusion, it's a paramnemonic effusion, which will help you in diagnosis by doing a CT thorax. And the role of CT thorax is very limited, and the role of ultrasound will be better than CT in pleural effusion. And sometimes it will be helpful in diagnosis of a mesothelioma, where you will get a effusion along with the multiple nodules in the pleura. And sometimes it may be helpful if we do a CT chest with contrast, which if they have a malignant nodules in the pleura, it will help you in diagnosis of causes of it. And I think bronchoscopy, the role of bronchoscopy and the role of imaging I think Yuvraj will be covering in detail about in the management. And I am coming to this pleural biopsy. I think he will be covering about pleural biopsy, thoracoscopy, and what is rigid and flexor rigid thoracoscope. He will guide you. And diagnostic yield of pleural biopsy is 60 to 80%. In case of a tuberculous pleural effusion, it may be 60 to 90%. And I think thoracoscopy, everything he will be talking to. Thank you, sir. I think the treatment part and the management part, I think Yuvraj will be talking to you. And in this previously for this past half an hour, I was discussing about what is the anatomy of the pleural fluid, how much is a normal fluid, how it is formed. Then I talked to you about the causes of transitive and pleural effusion and exudative pleural effusion. And I discussed about the how to find out the causes of pleural effusion, what are the cell color with the color and with the cell type and with the pH, with the LDH, what is Light's criteria and modified Light's criteria. Thank you, sir. Thank you for giving me this opportunity. I think Yuvraj can take over and further proceed with the management. Thank you, sir.
Professor. Thank you, Professor Dhansekhar, sir. Wonderful presentation about the approach to pleural effusion. So we touch all the exudate, translate criteria and how to differentiate TB and malignancy, how to diagnose each and every cell, biological marker, biomarker, everything. So very fantastic. So we'll have a question answer after the Dr. Yuvarajan sessions. May I request, can you stop share, Professor? You can stop share the screen.
Yes,
can you open? Yeah. Good.
Okay.
Yes, thank you. Oh, okay. Fantastic presentation on approach to pleural effusion. So next I call upon the Professor Dr. S. Yuvarajan. So one of the senior consultant professor, head of the department of Sri Manakula Vinayaka Medical College and Hospital, Puducherry. He is invited faculty of our national and international conferences like BronchoCon, SleepCon, and our NEPCon and the other ERS, European Respiratory and American College of Physicians Conference and all. He is an outstanding pulmonologist of the decade award from the in the meeting of the Nagpur by the government of Maharashtra, and he shared several sessions and many papers in peer-reviewed journals. He is one of the business practitioners in Puducherry. So Dr. Yuvarajan is going to speak about the management of pleural effusion. So far we have made the diagnosis. So how to treat the pleural effusions with a medical treatment or interventional treatment. How to there are various kind of treatment modalities. So when to refer to the case to the interventional pulmonologist for the diagnosis and treatment purposes. Everything, and Dr. Yuvarajan will delve in detail about that. I stop share my screen. Welcome to Dr. S. Yuvarajan.
Yes, sir. Sir, can you see my slide?
Yes, sir. Yes, Yuvarajan.
Yes, sir. Sir, first of all, my wishes and thanks to IMA headquarters and also IMA Villivakkam branch, especially Professor Dr. Jayaraman sir and Dr. Dhansekhar sir for inviting me to discuss regarding the management of pleural effusion in this wonderful meet. So without wasting much of time, I'm directly going to the topic of today's session, that is the management of pleural effusion, which is most important aspect that everyone should know. Even as a general practitioner, those who are practicing medicine, definitely this topic, I think everyone should know. In the last 30 minutes, Professor Dr. Dhansekhar sir discussed on the basics of how effusion is formed and what are the various modalities that we can use to diagnose a patient with pleural effusion and different approaches how to manage, how to diagnose a pleural effusion. So in these presentations, we are going to discuss what are the mechanisms that how the pleural fluid is formed that already Sir has touched upon. So I'm not going to discuss further things in that mechanisms and what are the different pleural interventions that you can perform to relieve the symptoms in patients with the presence with the pleural effusion. The most of the patients with the pleural effusion, they have symptoms of dyspnea because of the collection, the pleural space, and they present the dyspnea, they present the dry cough, and a lot of symptoms are there. But most worrisome symptom is the dyspnea, and you need to relieve the dyspnea in this group of patients. The most important thing that you can do is in this patient is that you can drain the fluid from the pleural space and to relieve the dyspnea. That is the most important thing. In addition to the basic care, in addition to the primary care to be given to the disease that is causing the pleural effusion. Generally, what are the principles that you should keep in mind in managing these two group of patients? And definitely, case-based approach would be interesting. So the real-time cases we're going to discuss here, so that it will give you an idea that how to manage a patient with pleural effusion. Sarah has discussed that how the fluid accumulates in the pleural space, mainly by three mechanisms, either because of increased drainage of fluid in space, or increased production of fluid by cells in space, or decreased drainage of fluid from the space. It's nothing but the ultrafiltrate from the plasma. So basically, when there is obstruction to the drainage, when there is a overproduction, there will be accumulation of pleural fluid in the pleural space, which cause symptoms. So these are the different mechanisms already Sarah has touched upon, because of increased capillary pressure that you see in cardiac failure, because of increased capillary pressure that you see in pneumonia, decreased pleural pressure in case of atelectasis, increased oncotic pressure in hypovolemia. All these things Sarah has discussed. So by this aspects like pleural effusion is formed in different diseases. So first thing, what I'm going to discuss with you all is that, like, the patient comes to you with symptoms, with worsening symptoms, with effusion, maybe a moderate to massive effusion. What the best thing that can be done immediately to relieve the dyspnea? So the best thing that can be done immediately to relieve the dyspnea, when the pleural effusion or the pleural fluid collection is attributed directly to the amount of dyspnea, you can drain the fluid. That's the best thing that you can do to the patient, that you can do by a simple thoracosynthesis. It's a OPD-based procedure that's otherwise called pleurosynthesis. You can drain the fluid with a needle. And also with a stopper, you can do a diagnostic thoracosynthesis, or you can perform a therapeutic thoracosynthesis, particularly if the patient presents with a moderate to massive effusion. Or in some situations, like in case of malignant effusion or in case of empyema or in pneumothorax, definitely ICD, intercostal drainage. You put a large drain, continuous drain to the pleura to drain the fluid. And the third thing is pigtail drainage. Like when compared to olden days, recent days, based on the recommendations from various international societies, we should not harm the patient so much just to drain. So that's why the guidelines, we have changed a little bit, that to avoid large pore drains. Don't put a ICD of large size. Use very small drains. For that, pigtail drainage is very, very important, because it's a very small drain and it don't cause much of pain or local discomfort to the patient. So that's why pigtail drainage holds good for the management of pleural effusion. And obviously, thoracoscopy is one of the important tool, medical thoracoscopy, that is performed by a pulmonologist, so interventional pulmonologist. So it can be used as a diagnostic modality, as Sir was discussing in his presentation, that most of the times we can able to diagnose effusion based on the various tests what Sir has discussed. So first thing, we have to classify the effusion as transitive and exudate, and based on the other additional investigation that you are going to send for the pleural fluid. So you can able to diagnose almost nearly in 80% of cases, you can come to a conclusion. But in 20% of cases, even after all the diagnostic tests, whatever are discussed, usually we could not come to a conclusion what causes this pleural effusion. In that case, we should go for other advanced tests, like you could take a biopsy from the pleura. Same thing, biopsy the pleura in olden days, they used to take blindly without any imaging guidance, to take with Abraham's needle and all. Sometimes you may miss the diagnosis. So nowadays we have armamentarium. We see what is there in the pleura under vision with the thoracoscopy, and we can take the biopsy. That will help us to diagnose in a precise way, especially in patients with suspected malignant effusion. And at the same time, this thoracoscopy can be used for a therapeutic modality. At the time of thoracoscopy, you are draining the fluid under guidance. At the same time, the patient have septations, or the patient have a lot of fibrous strands in the pleural space. You can remove, or you can cleave all the fibrous strands to relieve the pleural space, to relieve the compression, and then you can immediately relieve the symptoms. So we can use this as both as a diagnostic and therapeutic modality. Another advanced test, like you can do a lavage, you can do a brushing, you can do biopsy. That's what already I discussed. You can do a pleural manometry. That means that you can monitor the pressure in the pleural space. So what is the clinical implication of pleural manometry that Sir was already discussing in his presentation? That so you need to monitor the pleural pressure, especially when you are draining the fluid. Because when the patient presents to you with a moderate to massive collection, when you are going to relieve the symptom by draining the fluid from the pleural space, what happens is that once you drain the fluid immediately, the lung is an elastic structure. It tries to expand. When it suddenly expands, when you remove large amount of fluid at one point of time, maybe more than 1.5 liters. So what will happen is that sudden expansion of lung will create the environment, which accumulate the fluid inside the lungs. That we call it as a re-expansion pulmonary edema, and it is very difficult to manage. That's why in order to avoid that complication, it is always better to monitor the pleural pressure. And based on the pleural pressure, so you can just guide, it will help you to guide how much of fluid that can be drained, because no guidelines until now, nobody knows how much of fluid that you can drain at in a single session. But usually we stop roughly around within 1 to 1.5 liters, not more than that we will drain in a single setting. And the most advanced intervention that what we are doing in the patient with who have recurrent pleural effusion, either due to non-malignant and malignant causes, either due to underlying carcinomas or non-malignant causes. So in order to drain the fluid continuously, we can put a catheter, that is indwelling pleural catheter, that is catheters that are indwelled in the chest wall, involved in the subcutaneous space, so that which cause very, very, very less discomfort to the patient and also helps in relieving the dyspnea of his wound. So these are the different procedures we'll do. The thoracosis that already you see that this is a very simple procedure, OPD based procedure. We need 18G needle. You can use 21G needle or 18G needle with a 3-way stopper, with syringe, and with the IV set and all. You could always try to ascertain where you are going to insert the needle, because when you are going to drain a free effusion, in olden days we can put a needle blindly. But what our guidelines, our recommendations based on the BTS and different recommendations, what they're telling, under image guidance, if we do the procedure, that will ensure the safety of the patient. It avoid all the post-procedure complications. It avoid pneumothorax, because pneumothorax is one of the another terrible complication that you may expect after a diagnostic or a therapeutic thoracocentesis. To avoid that, under image guidance, where is the big locule, where is the collection, massive, where is the collection is there. So based on that only you can put the needle. So basically, the rule of thumb is that you insert the needle just in the upper border of the lower rib. Basically, you see that these are the rib, this is the intercostal space, these are the ribs, cross-section of ribs. You could see you should not put the needle immediately below the rib. As you know, this is the basic anatomy. Immediately below the rib, we have a neurovascular bundle structure is there. When you put the needle there, you tend to injure those structures. That is not acceptable in a diagnostic procedure or therapeutic procedure. So always you try to put the needle the upper part of the upper aspect of the lower rib. So to avoid all this neurovascular bundle, you always try to put the needle. So basically, where you have to put the needle is this is the basic principle. And then based on the ultrasound, where you are seeing a good pocket of collection, you can put the needle safely. You have to see the distance from the chest wall and the collapsed lung, and safely to avoid the injury to the lung from the tip of the needle. So under image guidance, we do that will be better to avoid the complication. That you should note in all the patient thoracocentesis. And next important procedure, pleural intervention that you do for patient with a massive effusion or massive effusion or pneumothorax or empyema and all is intercostal drainage. So what is intercostal drainage? It is nothing but putting a continuous drain as a small tube can be inserted in the chest wall. These are the different positions that you can ask the patient to opt. So this is a semi-recommended position. Usually we'll put ICD in this position. Sometimes the patient can be lean forward and then lean forward the cardiac table with the pillow and the support. And in this position also we can put an intercostal drain. It's very simple. It's also only a very simple procedure. So basically here the rule of thumb is that where you can put the ICD safely. Once again, with ultrasound guidance, if you mark the site and then you can put the ICD, that is much better. If it is not there, this is always better to put in the safety triangle. So what is the safety triangle? You could see anterior border in the lateral edge of pectoralis major, and posteriorly with the lateral edges latissimus dorsi, and the lower extent is the fifth intercostal space. You should not cross the fifth intercostal space. So if you put ICD in this space, the risk of complications secondary to the insertion of ICD is very, very less when you insert ICD in this space. So these are the different ICD intercostal tubes we have. These are the angulated drains, angulated tubes, chest tube. This is a straight tube. This is actually Malicot catheter that is very good for intercostal drainage, but we are not commonly using these catheters nowadays. And the fourth one is the ICD with the trocar. So ICD with the trocar is that it is very easy to insert because it's already having a sharp end inside that is inserted inside the tube. So what you have to do is that you put an incision and then you have to do a simple dissection with a blunt arteriforceps, and then you have to give a pressure with the trocar, and then easily you will cross the intercostal muscle and the space, and you can puncture the pleura and put the drain secure the drain in this patient. But the problem with the trocar is that it should be used by the experienced operators, because the trocar, the end of the trocar is very sharp, and you need to guide the ICD in very carefully, and you need to also assess how much of force to be given while inserting the ICD. So that's why trocar with ICD only with experienced operators. Otherwise, this ICD can be inserted by any residents also once they are experienced. You could say the procedure is simple. You should make a 2 to 3 centimeter transverse incision with the surgical blade in the 5th intercostal space anterior to the mid-axillary line, or with the USG guidance, you can select the space, or you can put the safe triangle. And before putting any needle or before putting an incision, definitely we need to give a local anesthetic agent. You should infiltrate the anesthetic agent deep from the pleura and to the intercostal space, subcutaneous space, and all these areas. And after a dissection with the blunt artery forceps, curved forceps we can use. Instead of straight forceps, we can use curved forceps, because once you give a pressure also, if you give a giveaway also, the curved forceps won't hit the lung, underlying lung, very in a forceful manner, and avoid the injury in this group of patients. So the proximal thoracostomy tube is clamped like this with the forceps, and then with the guidance of the finger and with this curved artery forceps, we can push the ICD into the pleural space and then secure the ICD for the continuous drainage. This is a very simple procedure in the experienced hands. So the next important thing, that's important palliative measure that you do in a patient with a recurrent collection, pleural effusion, is that if the patient is having a malignant pleural effusion, or the patient is having any non-malignant pleural effusion who is presenting to you with a recurrent pleural effusion. So what we can best do to the patient? For the best thing that you can do to the patient is you can do a symphysis of both the layers of pleura and close the pleural space. So both parietal pleura is closed with some chemical or mechanical stimuli that will induce the artificial pleural inflammation that will obliterate the space, so that the space is obliterated. There is no point, there is no chance that fluid gets collected and compress the lung, underlying lung, and cause dyspnea. So pleural disease is one of the best palliative measures that you can do for any patient who comes to you with a recurrent pleural effusion. So these are the different commonly used chemical agents that you can instill into the pleura to induce the artificial inflammation, and then to induce the inflammatory stimuli in the pleura, and then to fuse the pleura. The commonly used agents are talc, tetracycline, doxycycline, bleomycin, silver nitrate with talc is generally will be most effective. But based on the various guidelines, talc is, talc slurry, which can be given along the intercostal tube, is considered to be one of the most effective and well-studied agent. But actually, tetracycline, doxycycline is one of the cheap alternative, very cheap drug. It is commonly available in the clinical practice. We use 10 mg per kg of body weight. Usually 500 milligram can be instilled in the pleura for the better symphysis to be there for the fusion of parietal visceral pleura. So while both approaches require hospitalization, so you can put the sclerosing agent either by putting the chest tube, and through the chest tube you can put the sclerosing agent, or under vision when you are doing a thoracoscopy. At the time of thoracoscopy, after doing a biopsy and after draining the fluid, so you can put a pleural agent. Usually under thoracoscopy we use a talc pudraj. We spray the talc into the pleural space, into the pleural layers to induce the inflammation. So that's what I already told you. Talc has the best rate of success with pleural disease and is a preferred agent according to the BDS guidelines. A pleural agent can be instilled at the bedside via intrapleural chest catheter by thoracostomy, or you can use a medical thoracoscopy, or if the patient went for a VATS surgery, so we can give that to the surgeon. So under VATS also you can do that. So when the patient has failed pleural disease, what you can do further for the patient? Either you can do a repeat pleural disease, or you can do a repeat thoracocentesis. So both the options are failed, then what to be done? None other than we have to put a continuous drainage, like long-term indwelling pleural catheters and other things. So last option, we can go ahead with surgery like pleurectomy, that we are not doing commonly. These last two options we are not doing commonly. Pleuroperitoneal shunting, that means that connecting the pleural space to the peritoneal space. So once again, this is actually a disaster. So once you do a pleuroperitoneal shunting also, you are draining the fluid from the pleura to the peritoneal space. So once again, if the peritoneal is also filled, so it will also, give the pressure effect, and once again the patient presents dyspnea. So these two options commonly we are not using for our patients. So this is what I was describing. When the pleural disease failed, you have to put continuous drain. So when you are putting continuous drain, there are two things you should keep in mind. So when you put a continuous drain, the drain should be secured enough for long term. So you should choose a drain like that. And second thing, the drain should not get infected, because most of the times when you put a drain, the chance of infective complications is very high. So you should not get infected, and that it should be secured firmly, and it should be easy to drain. So all these things. So considering all these factors, indwelling pleural catheter is one of the challenging modality that we are commonly using for recurrent pleural effusion, even after all the modalities have failed in managing this patient. So how we insert the indwelling? So the name itself, indwelling pleural catheters. That means that these are the nothing but the ICD-like catheters. These are the small bore catheters, ICD-like catheters only. But here indwelling means the catheter has two entry points. The first entry point is the pleural site. So this is where the catheter enters into the pleural space. The exit point here, you see that here from that pleural space, the catheter is buried in the subcutaneous space. So what are the uses of this burying? So one thing is that the catheter is can be hidden in the subcutaneous space. And second thing, the catheter is very well secured without the suture also, because this part of the catheter that what we are burying inside subcutaneous space, that helps the patient to keep this catheter in a secure place, so without any suture. So that's an important use of indwelling pleural catheters. This allows them to stay in place for long periods of time, months also, if it is necessary. Once again, it's a simple drain. Usually we put the catheter with Seldinger technique. So here you give a local anesthetic agent, you put a needle, you put a guide wire through the needle, and then through the dilator, you dilate it and put an indwelling catheter in that. This is how it looks. You see that this is the external site. This is the area where it is indwelled. This is the area of site where it enters into the pleural space. So basically this is the area like it enters actually into the pleural space. From that site, we are indwelling. We are putting the catheter in the subcutaneous space and then putting that here. And you should see that how it is just. You know, it is getting so you can curve that. You can make a curve, and then you can fix that firmly with the dressing. So that's what we can do with the long-term indwelling pleural catheters. So what are the advantages of IPC? It's a day care procedure. You don't need any hospitalization. Whereas in pleural disease, you need to put an ICD. After putting an ICD, after the drain is reduced, then you have to put a pleural disease agent. Then you have to check whether pleural disease is success or not. Then you have to keep the patient. So maybe at least 3 to 5 days, you need to keep the patient in hospital. But in IPC, it's a day care procedure, OPD-based procedure. On the same day, you can discharge the patient. So only under local anesthesia you can do the procedure. It is less painful under experienced hands than a chemical or surgical pleural disease, because when you instill the pleural disease, any irritant to the pleura, as sir was discussing, parietal pleura is more sensitive area. It is infiltrated with the somatic nerves, so it is a pain sensitive area. When you irritate the pleura with any sclerosing agent, there will be a terrible pain after a pleural disease. So that's why most of the times we instill local anesthetic agent like lignocaine along with the sclerosing agent to avoid pain for this patient. The one thing in the olden theories and all, that we used to avoid this giving NSAID also to improve the success rate, but there is a different school of thought in that. So patient can self-manage their drainage, so they can able to drain of their own. They do not have to come to hospital for that purpose, and relieve the symptom as they occur. Avoid further hospitalization with this IPC. So thoracoscopy, that's what already we discussed. Thoracoscopy is one of the important armamentarium for interventional pulmonologists, not only to diagnose and also do some therapeutic interventions like breaking up the adhesions, removing the septations, and cleaning the pleural space to make the pleura free from the septa and all. So you can use this thoracoscopy. So we have discussed all the interventions that can be done to relieve the pressure, compressive effect of the collection of pleura, collection of pleural collection, to relieve the pressure. We have discussed all the interventions, but so what exactly you have to do for when the patient presents the pleural effusion? So I have to simplify this aspect, I have differentiated this topic to a pleural effusion due to benign non-malignant effusion and pleural effusion due to malignant pleural effusions. So first thing, we are going to discuss non-malignant pleural effusion, how we are going to manage, and second thing, how you are going to manage the malignant pleural effusion. As we all know that benign pleural effusion, that is non-malignant pleural effusion, are broad, heterogeneous, and the patients may benefit from individualized management protocols targeting the underlying disease process and direct management of fluid. That's what we discussed in the previous slides. So what is the problem with management of non-malignant pleural effusion is that we don't have a proper guidelines, or we don't have a proper consensus as we are having for malignant pleural effusions. We have a different RCT, we have a different observational studies for malignant pleural effusion, how to categorically manage this group of patients. But we don't have an exact management protocol for how to manage the non-malignant pleural effusion. For that matters, the pleural effusion second to failure, CCF, renal failure, uremia, urinothorax, chylothorax, pleural infections like paranomic effusions, empyema, we don't have a clear-cut guidelines how to manage that. Except for paranomic effusion, we have guidelines, BTS guidelines that was released in 2010. And as we are discussing, the most common cause of non-malignant pleural effusion, that is non-malignant pleural effusion, that is benign pleural effusions, or due to pleural infection, that is paranomic effusions, and congestive cardiac failure are most common etiologies. So generally, when the patient presents with the pleural effusion in this setting, so how you manage this group of patients? So primary disorder should be treated. This point is very important. All these patients, you should treat the primary disorder, and the pleural effusion should be drained. So if the patient presents to you with a dyspnea, and you are very sure that the dyspnea is due to the presence of this huge collection in the pleural space, so relieving the pressure by draining the fluid definitely helps the patient. But if the patient is having minimal effusion and the patient is having dyspnea, it won't do, draining the fluid won't cause much difference. So that's why always you try to confirm before doing a therapeutic thrombosynthesis, how much of this symptom is attributed to the amount of collection. So that you need to ascertain. And drainage can be done with the needle thrombosynthesis under USG guidance. That's what already I discussed. Asymptomatic patients with effusions do not typically need to be treated. You treat the primary cause and don't drain the fluid unnecessarily, unless they are symptomatic, unless their symptoms are due to the collection of the fluid in the pleural space. In most of the patients, this approach results in the complete or partial resolution of pleural effusion. All the patients should be followed clinically and radiologically until symptoms on effusion resolve. Perform a chest X-ray or ultrasound. The best will be the ultrasound because the real time and immediately you can perform at the bedside. At the interval time point when the underlying etiology is expected to improve. Maybe if you are suspecting a effusion is due to congestive cardiac failure in acute setting, you can repeat the X-ray in days to see whether the effusion is resolved after the treatment with diuretics. And you can do it in weeks in case of chronic heart failure. Suppose if the patient presents to you with the repeated collection, in case of cardiac failure, in case of renal failure, in case of any other non-malignant causes, persistent or recurrent non-malignant pleural effusion, how we can manage? A persistent or first recurrence of symptomatic non-malignant pleural effusion, the effusion to be redrained with the thoracosynthesis, with a needle thoracosynthesis, rather than proceeding for a definitive therapy. What is a definitive therapy? More advanced intervention. That's what already I discussed. You can close the pleural space by putting a sclerosing agent, or you can put a long-term drain. So what, based on the various consensus statement, based on my experience and other people experience also, any patient with a persistent or first recurrence of symptomatic effusion, don't go ahead with advanced interventions. So you can do a re-thoracosynthesis and then see what's the status of the patient. Repeat pleural analysis, underlying cause of NMPE should be reconfirmed. See, suppose if you are suspecting a congestive cardiac failure, the patient presents to you with effusion. And after treating the cardiac failure, after optimizing the therapy also, the patient presents to you with repeated collection. Then this is the point that you have to rethink whether you are going in the right path or not. So that in that scenario, you have to repeat the pleural fluid, all the analysis, all the investigation, and the underlying cause of this NMPE should be reconfirmed. This collection is definitely because of cardiac failure or some other attributable cause is there for the collection to prevent the recurrence. So that is very important in all these persistent cases. Once a primary diagnosis has been established, attempts should be made to ensure the compliance and optimization of therapy for the underlying disease. That's very important. So all the case of non-malignant pleural effusion, first you optimize the primary therapy, then you touch upon the pleural space. If it is assured that medical therapy has been optimized, even after that also, even after first recurrence, you have done a repeat thoracosynthesis. Even after that also, this recurs, then you have no other option. You have to go ahead with a definitive therapy to prevent recurrence. The patients with symptomatic NMPE, that is non-malignant pleural effusion, benign pleural effusion, that recur despite repeated thoracosynthesis, maybe more than 2 or 3 occasions. And after giving optimal medical therapy, we can either opt for two options based on the discussion of the patients and patient attendants. You can put a long-term drain, chest wall drain with an indwelling pleural catheter, or you can do a pleurodesis rather than doing a repeat thoracosynthesis. So pleurodesis is best suited to the patient with expandable lung, very important. So this is what, see, when you can approximate the 2 layers. So the 2 layers can be approximated only when these 2 layers are very close to each other. In other words, only in the expanded lung only, the visceral pleura and parietal pleura is very close to each other. The chance of adhesion, the chance of symphysis, the chance of fusion between the layers is very high when you do a pleural disease. That's why you always do pleural disease only in those patients who have expandable lung, who prefer to avoid inconvenience of repeat thoracosis or IPC. So you can choose a pleural disease in these patients. IPC is best suited, that is indwelling pleura best suited for the patients who fail or decline or not the potential pleural disease. For example, if you are having an endobronchial obstruction, if you are having a bronchial obstruction, if you have a large tumor sitting in the center of the bronchus, you don't expect the lung to expand after draining the fluid. So without expansion, putting a gum-like substance, putting a sclerosing agent in the pleural space and trying to approximate is a big, it's a big disaster. So you don't have to try pleural disease in this group of patients. So these group of patients where you don't expect the lung to get expanded, or if you are thinking of a lung is trapped because of obstruction, endobronchial obstruction, you can choose a long-term drain in the form of indwelling pleural catheters. For patients with a non-malignant pleural effusion who continue to have high output via IPC, or the patients who fail the pleural disease, so definitely you can combine both. IPC can be combined with the pleural disease. And the last two options very rarely we perform, like pleuroperitoneal shunts, pleurovenous shunts, and surgical pleurectomy are the last resorts, but we don't do in our patients, for our patients. So this is the first case scenario I'm going to discuss. This is a 62-year-old male who presented with a history of shortness of breath on exertion for 1 week, bilateral leg swelling for 1 week, cough with profuse frothy sputum for 1 week. So with the history only, you could come to a conclusion: cough with frothy sputum, bilateral leg swelling, shortness of breath, old age. So this history is typically like a congestive cardiac failure. On examination, tachypneic using axillary muscle respiration, raised JVP, pitting pedal edema, and S3 gallop. So the X-ray was like this: bilateral minimal pleural. You could see the blunting of CP angle. You could see the bilateral CP angle is blunted. So it is a minimal effusion. The patient is having dyspnea. For this patient, you don't have to drain. You don't have to do a diagnostic testing also, because we know that the bilateral effusion is minimal effusion is very common in CCF. There is no need to drain even diagnostic for diagnostic purpose also. If the patient having other symptoms, maybe a fever, maybe other atypical manifestation like maybe lung infiltrate or fever, or unilateral effusion, large collection is there. In that scenario, you can go ahead with diagnostic thoracosynthesis, or if you think that the large collection in the pleural space is attributable to dyspnea in that patient, you can do a therapeutic thoracostomy. Otherwise, don't touch this patient. So this was already discussed, like this pleural effusion to cardiac failure is due to the increased pulmonary capillary pressure and consequent leak in the pleural space, as we are discussing in our case. So basically, it is because of left ventricular dysfunction, maybe a systolic or diastolic, or valve dysfunction, or constrictive pericarditis. So what you have to do? So that, like already I told you, all the patients of non-malignant pleural effusion, first you treat the primary cause. The treatment should involve the medications such as diuretics, because the patient presents the fluid overload. Definitely, diuretics plays a major role in this group of patients to relieve the dyspnea. Not only to relieve dyspnea, to relieve the effusion also, we can use diuretics, and angiotensin converting enzyme inhibitors, beta blockers, and other drugs and other therapeutic options you can use to relieve the symptoms in this group of patients. So there is no need to do a diagnostic thoracosynthesis or therapeutic unless you feel that manifestation is there for this patient. So if you feel that despite isolated large and left side effusion being occurred, bilateral effusions are very frequent in this group of patients. Therapeutic pleurocentesis in symptomatic patients only in symptomatic patients with a moderate to massive collection. And you may expect this type of collection in post-CABG case also. In that patients also, you should not touch the patient unless otherwise you think of alternative diagnosis. This is a common scenario we see in day-to-day practice. 30-year-old female with a history of fever, low grade for the past 4 weeks, dry cough for the past 3 weeks, right-sided pleuritic, typical pleuritic chest pain for the past 3 weeks, loss of weight and loss of appetite for the past 3 weeks. See, in India, if you see a presentation like this, constitutional symptoms, the right-sided pleuritic chest pain, we always think of tubercular pleural effusion only. So breath sounds reduced in the right infraaxial infrascapular area. You could see the X-ray, you could see the effusion is there. There's a significant collection is there. Obliteration of costophrenic cardiophrenic angle. There is a silhouetting of right heart border. There's a collection is there. So what do you have to do in this case? So definitely for diagnosing tubercular pleural effusion, you need to do a diagnostic thoracosynthesis. So for that patient, these investigations were done, which were negative. This was the pleural fluid analysis. Typically, it was an exudate, lymphocyte predominant, ADA is high, 78 units per liter, and stock alert. This was the typical finding you expect in a tubercular pleuration. ADA is very high. ADA is 60 plus. Any ADA above 40 is diagnostic. Any ADA above 70 is pathognomic of TB effusion. So how will you manage this type of case? The first and foremost thing that you can do is that you treat the patient with ATT. So you can ask one question, sir, the TB pleural effusion is not a true infection of the pleura. It is actually a secondary to hypersensitivity of tubercular, but that's what the usual teaching is like that. But if you are not treating this patient with ATT, what they are going to do in future is that within a matter of 2 to 5 years, they present the full-blown pulmonary tuberculosis. That's why all these patients of tubercular pleuration has to be treated with the ATT, 4-drug regimen, daily regimen has to be given for 6 months. And pleural thickening invariably is avoidable. Minimal thickening will be seen in 50% of cases. So after starting treatment, if you feel that the patient comes to you, maybe TB effusion comes to you with breathlessness, what are the possibilities? So when the patient comes to you with the collection, if the patient is so breathless even after all the modalities, so what are the possibilities? You have to rethink your diagnosis, whether it is really TB or not. We are treating malignancy. So you have to do a biopsy or you have to do other things. Is there any role of steroids in TB effusion? Yes. In older textbooks and guidelines, there is a marginal role of steroids. Provided if the patient is more symptomatic with the TB effusion, you can give a steroid with the tapering dose. This is the third common scenario you see in a patient with a benign pleural effusion. A 54-year-old male with history of fever, chills, and rigors for the past 7 days, cough with yellowish purulent sputum for the past 5 days, right-sided chest pain for the past 5 days. Patient is a known case of type 2 diabetes mellitus on irregular treatment and is a known chronic alcoholic. On examination, patient looks toxic, is febrile, tachypneic, local tenderness on the right side of chest, breaststones reduced in the right infraaxillary infrascapular area. See, this was a chest X-ray finding. You could see the collection. You could see the right side effusion, and right side effusion is there. Moderate collection is there. So after doing a diagnostic thoracosynthesis, this was the picture. Protein around 5 grams, sugar around 10, ADA is 140, and pleural fluid cytology shows polymorphic predominance. So the nick is that it's a exudative effusion because protein is high, and here sugar is very low. Any patient who is having sugar very low, less than 40, you always think of some active metabolic, metabolic pathology is going on inside the pleura. Maybe a malignancy, maybe a rheumatoid, maybe a infection, ongoing pleural sepsis can cause a reduced sugar level in the pleural fluid. So that's why here you could see the ADA. One of the most common pleural fluid investigation is relied, so much relied for diagnosing TB pleural effusion is ADA. See, here ADA is very high, but the cytology shows a polymorphic that is neutrophil predominant. So can it be tubercular? Yes, it can be tubercular, but actually when the ADA is very high, more than 70 or more than 100, so high ADA, you should rule out other possibilities also. So ADA is elevated not only in TB, you can get elevated ADA in empyema, you can get elevated ADA in paramnemic effusion, you can get elevated in lymphoma. All this other condition has to be ruled out when you get an exorbitant elevation of ADA. That's a learning point that you should note in this slide. So this type of patient, like a patient is having a pleural sepsis, how do you manage? So basically for paramnemic effusion, you can classify based on the Lights criteria, based on the Lights classification. So class 1, class 2, class 3, 4, 5, 6, 7. So here you could see the class 1, there is no need for thoracosynthesis. Class 2, only antibiotics needed. Class 3 is a borderline complicated effusion. You can give antibiotic serial. So basically, based on the class, you can manage. So what are the indications of draining the fluid when you face a collection? A patient who presents the frank pus, definitely you need to put a drain. The presence of any organism in the culture, definitely you put a drain. Or any patient, the pleural fluid pH less than 7.2, definitely you should put a drain. Already I discussed this. Any patient who have a low pleural fluid glucose, definitely put a drain. And patient with the loculated pleural correction, definitely you have to put a drain. So how will you manage? What drain you should put? Already I discussed it in my previous slides that you should not give so much of harm to the patient. Always select a small bore catheter that is 10 to 14 French only, as per the international guidelines. Even for drainage, maybe for a thick pus, you can slightly choose a large drain. But as per the recommendation, you always try to choose a small drain to avoid discomfort to the patient. Chest tube insertion should be always performed under image guidance, and this insertion should be performed in line with VTS guide. That's what I told you. Always choose a small bore drain. Antibiotics, definitely pleural sepsis antibiotics you should choose. So what antibiotic you have to choose? You have to choose an antibiotic which penetrates very well in the pleura, which achieves a very good concentration in the pleura. And always try to do a coverage for anaerobic organism, because any suppurative disease, in case of empyema, paranemic effusions, in case of lung abscess, most of the times the organisms are polymicrobial, includes aerobic organism, anaerobic organism. So you need to give coverage for aerobic and anaerobic organisms. So always try to send the culture of the fluid, and you have to manage the patient according to the culture report. So the antibiotic penetration in the pleural space will be in this order only. So metronidazole have a higher penetration than penicillin. Penicillin have a higher penetration than clindamycin. Clindamycin having higher penetration than vancomycin, then ceftriaxone, then centamycin. So if the patient is allergic to penicillin, you can they can be treated with clindamycin alone or in combination ciprofloxacin or cephalosporins. Always try to prove by culture. So based on the culture, you can change the antibiotic. So what is the role of fibrolytics? If you see a pleural infection, what you expect is the multiple septa, multiple loculations you will commonly expect in this group of patients. So that will reduce the drain output. So in this group of patients, you can use the intrapleural fibrolytis to cleave all the septa and to cleave all the fibrous strands to remove the collection, because removing the infected collection is one of the primary aim in most of the suppurative disease. So these are the different two trials are commonly or done for the use of intrapleural fibrolytics. That is MIST-1 trial and MIST-2 trial. They use streptokinase, urokinase, and all these drugs to improve the success of drain. Obviously, thoracoscopy, if you have a thoracoscopy, you can directly go ahead, you can remove the adhesions, you can remove the collection under vision. So other common scenario, what you see in a non-malignant pleural effusion is hepatic hydrothorax. The name indicates that any patient with the liver cirrhosis and ascites, these patients will have a collection in the pleura. They are called hepatic hydrothorax. They are mostly right-sided, maybe bilateral collection also. They can present without ascites also. So any patient who presents with a moderate to massive collection in a patient with the cirrhosis, when you diagnose it, it's because of hepatic hydrothorax, they have a poor prognosis. What you can do a salt and fluid restriction. You can do ascitic tapping to avoid percolation of fluid from the peritoneum to the pleural space. That's the best thing you can do. So once again, I'm repeating, all these cases, you treat the primary cause. So here problem is cirrhosis of the liver. So you have to do a liver transplantation. That's the most important definite treatment. In between liver transplantation, you can go ahead with the tips. Okay, transjugular intrahepatic shunts that you can do as an interim measure. And what we are discussing here in hepatic hydrothorax, because of the diaphragmatic defects only, all the fluid from the peritoneal space is percolating to the pleural space. So you can also send a patient to a surgeon for VATS to close the diaphragmatic defects so that the fluid from the peritoneum won't enter to the pleural space. And indwelling procatheters. So even after all these things, nothing could be done, means you can either choose indwelling procatheters with the presence of tips. So that will improve the success rate in this group of patients. Effusion and renal failure, obviously, most of the patients, CKD and ARF and all, we face effusion as a common problem. Nearly 20% of the patients present the effusion, particularly on dialysis. Most of the times it's because of volume overload. The remainder are attributed to heart failure, uremia, and infection. Remember, a patient with a CKD, always they are immunosuppressed. So you need to rule out all the infective possibilities when you see a pleural effusion in this group of patients. So those who develop exudative pleural effusion on long-term hemodialysis, the most common cause is uremic pleuritis that commonly we see in a patient on hemodialysis. So what you have to do, like basically you treat the primary cause. So when you see a pancreatic effusion, how do you manage? So basically you drain the fluid and you do a conservative management of pancreatitis. The pancreatic effusion is because of the enzyme rich, the pancreatic enzymes released into the pleura, irritate the pleura and make the pleura to secrete more collection, more effusion. So that's why you do a conservative management of pancreatitis by putting a nilperoral nasogastric suction, TPE and somatostatin analogs. It will reduce the collection in the pancreatic effusion. In chylothorax, once again, you treat the primary cause. That's the thing. So we have discussed what you can best you can do for the non-malignant effusion. The most important part we need to discuss for managing effusion is that how you can go ahead with a malignant pleural effusion. So malignant pleural effusion are caused by infiltration of cancer cells in the pleural tissue that may result in the positive fluid cytology and can be seen in the pleural biopsy. Commonly complicate patients with the lung cancer and malignant mesothelioma, but can also complicate metastatic cancers, lymphoma, and other hematological malignancies. Sometimes even in malignancies also, you may get effusion which are not malignant, that is paramalignant effusion. That means that the cytology will be negative for cancer cells, but this is actually a effusion, which is not direct, which is indirectly related to malignancy. These are the tumor effects that indirectly act on the pleural space to increase the pleural effusion. That is indirectly with the bronchial obstruction, mediastinal lymph node infiltration, pulmonary thromboembolism, and SVC obstruction. All these things can cause a collection, but they are not truly malignant. They are because of the obstruction, because the pressure affects the collection occurs in the pleural space. So this is a case of 60-year-old male who presented to the hospital with complaints of dyspnea, with weight loss, significant weight loss, with the dull aching chest for the past 2 months, and hemoptysis for the past 1 month, and no history of fever. You could see the collection, you could see the massive effusion, upside effusion with a significant mediastinal shift, both upper and lower mediastinal with the tracheal shift is there. So the collection was aspirated under guidance. So it was showing hemorrhagic fluid, exudative, sugar was low, ADA was 10, and LDH 2000, and cytology is lymphocyte predominant. So here actually cytology is not showing malignant cells. So what next you have to do? You have to sample the pleura. So for that we need to do a biopsy, pleural biopsy. Here you could see the sugars are low. That's what I already discussed. Any metabolically active cells, when that is present in the pleura, the sugar will be low. In that matters, you can expect a rheumatoid effusion. You can see this type of picture in case of malignancy, because malignancy that are metabolically active consume all the glucose, so pleural glucose will be on the lower side, and in case of pleural sepsis, pleural glucose will be low. So in all the case of management of malignant pleural effusion, what you have to keep in mind? So malignant pleural effusion typically signifies advanced stage of cancer. Usually indicates that death will be likely to occur in months or years. The focus is mainly palliative to relieve the dyspnea. Patient-centered goals include a sustained symptomatic relief you have to give to the patient, improvement in the quality of life that also you should consider, acceptability of intervention, what you are going to do. You can't do advanced intervention, you can't do a more painful and harmful intervention to the patient without discussing to the patient and patient attenders, affordability of the patient based on the intervention what you are selecting, and always think about the patient and choose a less invasive procedure in these patients. So therapeutic drainage has to be opted for all the patients because most of the malignant pleural effusion presents to you with a moderate to massive collection of the pleura. For most patients initially present symptomatic malignant pleural effusion, we recommend therapeutic large volume thoracocentesis as the initial intervention rather than straight away proceeding with ICD or any continuous drains and all. Thoracocentesis determines the symptomatic response to the drainage and the ability of them to re-expand completely, and the rate of subsequent reaccumulation can be assessed after draining the fluid in the first visit. Asymptomatic malignant pleural effusion that are in small volume does not require any therapeutic drainage, since early drainage does not prevent the progression of effusion to lung entrapment, which is best suited for chemoresponsive tumors. So over half of the patient experience the recurrent collection. So these patients you have to target and you have to do a definitive care to these patients. Among these, up to 2/3 recur rapidly within 1 month. That is one of the disaster that you face in a patient with a malignant pleural effusion. So the next thing you have to consider is all these patients you have to treat the primary etiology. For the systemic therapy is very important, except for the chemoresponsive tumors. So basically what happened, like in certain tumors responds very well to chemoradiotherapy, particularly for instance breast, ovary, prostate, and lymphoma. These group of patients don't do aggressive pleural interventions, don't do a repeated thoracostomy, don't do put a large drain and all, because these tumors very well respond to your chemoradiotherapy. After giving chemoradiotherapy, definitely there will be a decrement in the pleural fluid collection. So all the definitive therapy for this group of tumors you have to delay. So MP in the non-small cell cancer, particularly in case of adenocarcinoma and all these things and all. So malignant pleural effusion, the response to systemic therapy is disappointing. But nowadays we are using target therapy, geftinib, elotibine and all. So geftinib, elotibine and all, that changes the scenario. So malignant pleural effusion due to this adenocarcinoma also responds very well to this agents. So these group of patients who are responding very well to these agents, you should avoid aggressive management protocols, this group of patients. So radiation therapy directed at the primary tumor may be helpful in resolving MP with the predominant mediastinal adenopathy. Intrapleural agents also you can give in selected patients, for example, Malignant Mesothelioma, but which have a partial and complete response. We don't have a clear-cut consensus statement on this. So next important thing is that when the patient presents to you with the recurrent malignant pleural effusion, what you can do? You can put a continuous drain in the form of indwelling pleural catheter, or you can close the pleura with a pleurodesis. For patients with a trapped lung, that is, the lung is not going to expand after draining the fluid also, the best option will be IPC, because already I described this phenomenon that when the lung is getting trapped, you can't fuse both the layers of pleura with the pleural disease. So pleural disease will be an utter failure in this group of patients. So only we have to depend on the drain. So in patient who got an expandable lung, so in that group of patients, you can go ahead with the pleural disease. Those patients who got a rapid accumulation, you can choose either with IPC or pleural disease. That is high output efficient, you can put a drain. Those patients who got a slow accumulation, after draining the fluid only, you can assess whether the patient comes to you repeatedly with the symptoms. Those patients who got a slow accumulation with the insidious progression of symptom. So in that group of patients, you can very well go ahead with the repeat thoracosynthesis, or you can go ahead with the IPC based on the patient preference. Minimally invasive procedures are always preferred in patients with a poor prognosis. So already I discussed this. What you can choose, IPC or pleural disease? IPC is best suited for those patients with shorter survival, less than 2 months, and for patients who prefer outpatient management or patients who prefer minimally invasive intervention. And it is one of the best important intervention that you can opt for the patient with a non-expandable lung, that is a trapped lung. So it reduces hospital stay. It can lead to spontaneous pleurosis. With IPC only, by putting the drain continuously over the pleura, it can irritate the pleura. It can only achieve the spontaneous pleurosis without using any agents. That is one of the additional advantage with the use of IPC. What are the main problem is that availability, the cost of the IPC. A single IPC costs around 20,000. That's one of the problem. And infection risk also very low. It can be you can easily manage, and proper care should be given from the patient attenders. Pleural disease is best suited for the patient with expandable lung who has a reasonable survival. The point is very important. You should ascertain that the patient is going to live for more than 2 to 6 months. Then only you can opt for the more invasive procedure like pleural disease and all. Because I already described pleural disease, you have to put a drain and you have to instill the sclerosing agent, which is painful and harmful to the patient. That's why you have to select. So there are always confusion based on the various guidelines and interventions, whether you can choose a chemical or mechanical, which type of agent you can choose, whether you can choose a talc or doxycycline, codeine. According to various literature, you can use a talc, whether you can go ahead with a medical or surgical closure, otherwise we can do a pleural disease with IPC or ICD tube, or we can put a large bore drain or small bore drain. According to different literatures and different international guidelines, always try to choose a small bore for the patient comfortability, talc and others, and duration of chest tube and post pleural disease. All these things are always is a matter of debate when you see most of the guidelines. So when you see a proved malignant pleural effusion, if the patient is asymptomatic, do a diagnostic procedure. As a diagnostic procedure only, you can do a thoracosynthesis. You don't have to drain the effusion in this group of patients. So any patient who is symptomatic because of collection, who is having a known malignant pleural effusion, evaluate the approximate survival chances of the patient. If the patient is going to survive less than a month, you can go ahead with a simple procedure like therapeutic thoracosynthesis. If the patient is going to live for 1 to 3 months, you can go ahead with tube thoracostomy, that is ICD. If the patient is going to live more than 3 months, then you can go ahead with aggressive procedure planned for pleural disease if there is no contraindications. This is the recommendations from BTS. A patient with a known malignant pleural effusion is symptomatic because of large collection. If he is symptomatic, definitely you need to refer to a interventional pulmonologist or a pulmonologist. So the first thing you have to do a therapeutic pleural aspiration. Approximately around 500 to 1500 ml you can aspirate, and you can see the prognosis. If the prognosis is more than 1 month only, you can go ahead with the advanced interventions. If the prognosis is less than 1 month, try to re-aspirate and don't harm the patient. So the patient is having a prognosis of more than 1 month. If it is yes, then you have to assess the expandability of lung. You see the patient whether after draining the fluid, whether lung is expanding or not. If the lung is expanding completely, okay, if the lung is expanding completely, there is no trapped lung, then go ahead with all the advanced interventions like Plural Effusion drainage, pleural disease, either with the ICD or with the thoracoscopy, and then you can close the pleural space. That's the best way of managing the patient with the symptomatic malignant pleural effusion. If the patient is having trapped lung, that is non-expandable lung, there is no option. The complete trapped lung, you can't put a drain continuously, and you can't you can put a drain continuously. You can't close the pleural space of pleural disease. So like already I described to you, pleural disease is highly unlikely to be successful in this group of patients. So you always have to consider indwelling pleural catheter or long-term catheter in this group of patients. So after this also, after pleural disease also, if the pleural disease is not successful, then you can go ahead with the indwelling pleural catheters. So basically, for the management of pleural effusion, what we have discussed is that first thing, to confirm the diagnosis, whether we are going in the right path, After confirming the diagnosis, treat the primary cause for the effusion. That's the first and foremost thing that you have to do. For malignancy, go ahead with chemotherapy. For non-malignant effusion, go ahead with the systemic therapy. Whatever congestive cardiac failure, treat with diuretics and all the optimized therapy. For CKD, do a proper dialysis, and you can, if the patient is because of coming repeatedly because of volume overload, you can increase the frequency of dialysis and avoid ask the patient to follow the strict protocols of fluid restriction, salt restriction, and all. If the patient is a hepatic hydrothorax, try to treat the cause and treat the etiology. If the patient is having pleural sepsis, try to remove the sepsis, try to drain the fluid completely from the pleura, and try to remove the adhesions of the pleura and give the proper antibiotics. So basically, based on the disease, you can manage the patient properly. So if there is any queries, I'm ready to take. Thank you, one and all.
Thank you, Yuvarajan. Wonderful, awesome presentation about the management of pleural effusion, starting from simple therapeutic aspiration, and the treatment of the basic cause is a very, very important thing. If it is a tuberculosis, you have to start ATT. If it is a malignancy, you have to start chemotherapy. If it is a transitive due to congestive heart failure, you have to treat the with the anti-failure management and dialysis for renal disease. So wonderfully explained from the simple aspiration to the inbuilding pleural catheter and the thoracoscopic pleural disease, etc. So wonderful, awesome. We'll move on to the question answer. This thing. So question: how long we have to give steroids in a case of tuberculous pleural effusion?
Yes, sir. Sir, as already I described, sir, this is a matter of debate. Actually, there is no clear-cut indication for giving a steroid for TB effusion per se. Because for in a case of tuberculosis, except for CNS TB and other adrenal tuberculosis and other very few causes, we can give go ahead with steroids. For TB pleural effusion, the indication of steroid, as per the older guidelines, is that those patients who are presenting with the symptoms which are not correlating with X-ray, maybe the patient is more breathless, having more chest pain, so we can go ahead with steroid. And second most important indication of giving steroid in TB effusion, even though that is very rare, is that INH induced effusion. So INH induced lupus effusion, maybe because drug induced lupus may be induced by effusion. So in that aspect, you can confirm the diagnosis by doing anti-histone antibodies, and then you can use steroids. So duration of steroid, if you are opting to give steroids, not more than 3 to 4 weeks, sir. Not more than that.
Oh, fine, fantastic. I agree fully with you.
And usually in pleural effusion, tuberculous pleural effusion, previously we are giving steroids, but nowadays we stop giving because of the ultrasound we can tap as much as possible. The treatment dictum is you have to remove fluid completely. The main aim of giving steroids is to prevent fibrosis, pleural fibrosis. So if you aspirate the fluid completely, you won't get the fibrosis. So now we don't use routinely the steroids in pleural effusion.
Thank you, Professor. One more question. Intrapleural thrombolytic therapy in a case of loculated empyema. So how much dose we have to give? What drug we have to give? Whether streptokinase or urokinase? How much? How long we have to give? Daily or
Yes, sir. Sir, intrapleural fibrinolytics. Actually, I'm repeating the statement that it is actually helpful in some cases only. There is no clear-cut concern that 100% for all the separated effusion, you can go ahead with the intrapleural fibrinolytics. We have commonly used fibrinolytics is streptokinase, TPA, and all these things. The tissue plasminogen activator, all these things can be given. But streptokinase is commonly available. It can be easily used. But based on the various trials, the success of streptokinase is that the output of the fluid output is can improve. But the difference is not statistically significant. That's what the MIST trial is telling. So how much dose? What we are using actually for streptokinase is 2.5 IU, 2.5 million units that can be given twice daily. That can be given twice daily for at least 3 days. So before giving streptokinase, 2 things you have to ascertain. The first thing is that you are seeing this paranoid effusion early or late. So any patient who are presenting to you in the early phase, that is within 7 days or within 7 to 10 days, you can go ahead with intrapleural fibrinolytics. Any patient who are presenting to you very late, that is the thickened pleura, that are the clear-cut cases for actually aggressive interventions. So in that group of patients, your intrapleural fibrinolytics won't work. So dose is, once again repeating, sir, 2.5 million units has to be given intrapleurally twice daily for at least 3 days. So usually not more than 5 doses we'll give, sir. Most of the times after 5 doses, you will have hemorrhagic collection. Hemorrhagic collection will be there in the drain. It will stop. And before
Fine.
giving a drain, it's always better to check INR also, sir. Particularly
Always,
if you are facing a systemic
choosing the
disease,
patient
INR
is,
also less than 1.5, sir.
always the choosing of the patient is more important in this type of streptokinase. Now we, with the advent of flexi-rigid thoracoscope, any case like this can be done with the flexi-rigid thoracoscope, and you can remove everything, adhesions, everything clearly. So most of the time, the choosing of the cases are more important, and if there is a very small lockulated in that type of cases, it may help.
Sir, guidelines, what they are telling, TPAs are more successful. TPAs and DNAs are more successful than streptokinase, but our patients can't afford this drug, sir.
But we also usually routinely follow streptokinase.
Okay, thank you. One more question from Dr. Surendran. There is a regarding the, can you show some light on the re-expansion pulmonary edema? That is, kindly throw some light on management of re-expansion pulmonary edema. Is there any guideline for the management? For
That's what in my presentation itself I told you. You have to decide on the aspiration. While aspirating, if you have a manometry, if it is safe, you can decide how much to remove, how much the pressure, everything can be calculated according. If you are removing blindly, but most of the time you are not following with the manometry because it is not available routinely. So if you aspirate, you have to look for the symptoms first. If the patient is having cough continuously, the patient starts coughing itself, you should be alert, and then you should stop removing the fluid. So that is a main thing. There's a first symptom where you have to tell them to stop the aspiration, which we can prevent the re-expansion pulmonary edema. Or you can take maximum around 750 to 1 liter, and then you should not remove more than 1 liter because they are more prone for developing re-expansion pulmonary. What is re-expansion pulmonary edema? Suddenly gushing of blood while the opening up of the lung will cause a sudden re-expansion pulmonary edema. To prevent that, you have to look for the cause, look for the symptom of the patient is having cough, or if the patient feels chest tightness, you should be alert and stop the procedure.
That's the same thing, sir. There is no guidelines is there for managing the re-expansion pulmonary edema. The best thing I can tell you all that you should avoid this re-expansion pulmonary edema. The best thing is prevention, then a treatment. That's what Professor Dr. Dansegar sir has explained very clearly, that you should avoid re-expansion because it's very difficult to treat. There is no proper guidelines or statement how to manage and all. Once it is there and is there, it's very difficult to treat. The first thing is that avoid large volume thoracosynthesis. So as sir told us, 750 ml to 1 liter only. And second thing is that when you are draining the fluid, so just see that whether it is a rapid collection or slow collection. In case of slow collection, that means that there will be definitely some amount of thickening of pleura will be there. So the rapid expansion, the possibility is very less. So for rapid collection, with the help of manometry, those who are present with the rapid collection, you can go at with the manometry and drain it. So don't drain blindly in this group of patients.
Yeah, correct.
I think one of my postgraduate is doing a study on this manometry.
Yes,
in
sir.
The next, we'll probably get you guidelines now, how much to aspirate, when to stop, everything we are looking into it, whether the transitive effusion, exudative effusion, everything we are going to come out with the guidelines, come out with the answers in the next 1 year.
Okay.
Yes,
yeah, this is a practical question. How do you manage in a case of re-expansion pulmonary edema? Suppose patient developed after the 750 ml patient developed
it's only a symptomatic management, sir. It is only a symptomatic management.
Symptomatic means
the
backless
patient
oxygen.
And if the patient sometimes may go in for a ventilator support also, or an NAV, you control and you maintain the oxygenation. That will be a better one.
There is no proven pharmacotherapy, sir, that can help the patient. That's what initially I told. Only you can, best way is to prevent the re-expansion pulmonary edema than the treatment.
Okay. One more question is, do Lasix and CPAP may help in the case of re-expansion pulmonary edema? Yeah, CPAP
maybe CPAP can help. Lasix.
throw some light on post-COVID effusion. How often you are seeing in the practice post-COVID effusion?
Post-COVID effusion is very rare, sir. Very, very rare. I have not seen. I think you are. Have you seen any
No, sir.
post-COVID?
No, sir. Only effusion I have seen two cases in acute setting, sir. In acute setting, I have seen 1 or 2 cases only. That too patient is a known cardiac disease patient. Nobody is dared to aspirate the patient, sir. At the time of acute phase, we don't know what is the exact etiology, whether it's because of cardiac pathology or because of COVID. But as per the literature, effusion per se in COVID or COVID-related symptom is very, very rare. It is seen only in less than 5 to 10% of cases. And if it is there, that is seen mainly in severe cases. Only in severe and critical ill patient, you will be seeing this pleural effusion. And when you see a pleural effusion, that is indirectly a poor prognosis for the acute COVID pneumonia. This is what guidelines is telling, sir.
And in COVID, most common pleural involvement is a mediastinal emphysema and pneumothorax is more common rather than a pleural effusion.
Yes, sir.
Thank you. One more question from Dr. Vishwanathan. How to diagnose subpneumonic effusion in X-ray chest and treatment? Subpneumonic or subpulmonic?
I told you in the X-ray, if you will have a PA view, if you have a lateral peaking sign, you can confirm the diagnosis of a subpulmonic effusion. If you have an ultrasound, you can readily, with an ultrasound, you can pick up very large collection or a subpulmonic effusion can be easily made out by ultrasound. In radiology, the sign is a lateral peaking sign, which I showed you the X-ray and PA view as well as the lateral view, how it looks like.
Thank you. A lot of comments about a very nice presentation and all. So thank you, Professor Dhanashekhar and Professor Yuvarajan. Wonderful presentation about how to approach to pleural effusion and modalities of treatment, starting from the simple aspiration, ATT with the steroid plus or minus, and malignant pleural effusion, how to approach. So the role of ADA level, ADA, if it is 40 to 70, so it's only we can say diagnosis of tuberculosis. If it is very, very high, so we have to think in terms of other alternative diagnoses. The role of biopsy is very, very important for biopsy in the case of, in our country, so commonest pleural effusion is tuberculosis pleural effusion. So sometimes we overdiagnose tuberculosis pleural effusion. In the case of malignant pleural effusion, we overdiagnose as TB. So the basic investigation to start with the fluorosynthesis. Fluorosynthesis is very, very important. In that, we must check the sugar, protein, the Light's criteria we must follow thoroughly, and with the lymphocytic and all, we must check. And the this cytology, whether positive or negative of malignant cells. If it is a dilemma, ADA is within normal limit, cytology negative, any smoking history, 50 plus, occupation history, so we will go for biopsy to clinch a diagnosis and start the specific therapy. If it's a bilateral pleural effusion, the common cause is congestive heart failure. We have to treat the basic cause. So very wonderfully, both the speakers nicely presented about in depth about pleural effusions. So I thank you very much on behalf of the IMA headquarters and the IMA College of General Practitioners with a wonderful presentation. With that, I conclude this pleural effusion session. I thank you both the speakers. A wonderful narration of pleural effusion. So thank you very much, Professor Dhanashekhar and Professor Yuvarajan. Thank you very much. Tomorrow we have a wonderful session, interstitial lung disease. There are 2 eminent speakers. The first speaker, diagnosis of ILD by Dr. Deepak Talwar, MDDM from Noida, and the second speaker, treatment of ILD, Dr. Sindhura, MD HCCP from Fortis Hospital, Vadabalani. So tomorrow 8 p.m. sharp. So we'll join the meeting. I request everyone please join and convey the message to everyone to join this meeting. So with that, I thank you, College of General Practitioner, Rekha ma'am, and the IT Yogesh. Very nice, wonderful show. Thank you very much. Over to Rekha ma'am.
Thank you, speakers. We had a very mind-boggling session and really an excellent presentation by Professor Dhanashekhar and Professor Yuvarajan. And very happy to conclude day 3 of our webinar series. And we hope to see you all tomorrow. Thank you very much.
Thank you, madam. Thank you, Yuvarajan.
Thank you, sir. Thank you.